Dear friends, we just had a very, very important information about the imaging. And I have two more personalities, again from the same field of imaging. How we can enhance the potential of imaging has to be very well understood. I have with me Professor Priya Jaggia, Professor of Imaging from All India Institute of Medical Sciences, New Delhi, and I have with me Professor G.N. Mahapatra, who is a great nuclear imaging personality from Mumbai. We'll have some discussion in reference to the cardiology. Priya, my first question to you is, we see so many patients coming to us with a coronary artery disease. They have an underlying viable or a non-viable myocardium. At times, it's very difficult. We do a lot of dobutamine test with a low dose and a high dose and see what is the ischemic response. But with the low dose, we can find out the viability response.
Yeah.
We'd like to ask you, if we were to choose one technology after the two, what is your preference? If there is a preference of CT, why not echo?
For the viability imaging, I think MRI is the investigation of choice. It is the investigation of choice for evaluation of ventricular viability. After you have done echo, you have seen dyskinetic segment or you have seen akinesia and you want to assess for viability, I think you should ideally go for MR viability. Viability actually means to see whether the tissue is viable, that is whether it can be revived or not. It is a tissue which has undergone some damage, but whether it is reversible or not. So when you are seeing some abnormality in the regional wall motion abnormality in the echo, you are not sure whether you want to revascularize the vessel, whether the ventricular wall will bounce back, whether it will recover or not. So viability is the testing which we do for on MRI to see whether after revascularization there will be an improvement in the function or not. So that we do after giving the contrast, and we see after some time how the ventricle, how the contrast remains. We can tell how much is the degree of fibrosis. If there is a lot of fibrosis, if say the entire thickness of the ventricular wall is fibrosed, then we say the viability is almost nil. But if the thickness involving of the fibrosed the myocardium is say 50% or 25%, then there are more chances that this tissue will bounce back after revascularization, and we say yes, there is a viability there.
Yeah, I think that's very important information you are giving. The number of times a patient come to us walking in the clinic, and we really have to assess the viability. MRI may be a good modality.
Yeah.
But an intensive care unit, when a patient comes in emergency, they are in a state of cardiogenic shock, or they are in a multi-system involvement, to assess viability is a little difficult. The reason is patient is to go to the MRI center.
Definitely.
So I feel the mobile echo is much superior there.
Definitely. Echo, we cannot replace echo. Echo is something which is available all the time. It's available in most of the hospitals. Cardiologists are familiar with it, though it is an operator dependent modality, but you are very, very familiar with it. So your screening has to be always with echo. And then only when you think that this patient can undergo MR, then only you can send the patient for an MRI.
So I think Priya has given a very clear-cut answer that so far as intensive care is concerned, or in emergencies when a patient comes and you really want to know about the viability, echo is definitely superior.
Yeah, definitely.
But otherwise, if a patient comes in the clinic, I think the right way is to subject him to the MRI.
MRI, we can do also
give you a better idea and give you a better information.
CT can also be used for viability purposes, but then the amount of radiation involved, you give contrast twice over for the coronary also and also for the viability. So MR is the investigation of choice for the
MR
viability.
is going to be superior. I think both the ladies are talking of MRI. The future is going to be MRI. That's what I feel. And I really love MRI more than the CT because of his positive potentials as compared to CT. We see a lot of hypertrophic cardiomyopathy these days.
Yeah.
And even those who are not cardiomyopathy, but they are hypertrophy because of hypertension.
Or amyloid,
Do you think MR is again a better modality?
Yes, definitely. Not only for diagnosing the hypertrophic cardiomyopathy, but for having a baseline reference, because all said and done, echo is an operator dependent, thing. Today you are measuring it at some point, next day you are measuring it at some other point. So if you want a reference point for the myocardial thickness, then MR is the way to go. It can also help you prognosticate the treatment. You can see the amount of thickness even after you have done alcohol ablation. You can see how the patient has responded. You can again measure the wall thickness. So MR is advisable not only for the diagnosis, for prognostication, for follow-up after the ablation, and also for follow-up over the year, how the patient has fared.
Very nice. I think the Priya has mentioned a very important point, that the MR modality is a very important modality, not only for diagnosis of hypertrophic cardiomyopathy, but also seeing the therapeutic response. If a patient is to undergo radiofrequency ablation, or a alcohol ablation, or even after myomectomy, if you really want to see there's a regrowth of the septal growth, or prognostically is there worsening or there's an improvement, I think can be easily assessed by MRI. Though as an echocardiologist, I also believe that the echo is also a very important modality for hypertrophic cardiomyopathy, because we see the important ingredients in the form of systolic anterior motion of the mitral valve apparatus, as well as we find the asymmetry of the interventricular septum, and we can see the hemodynamics better. Like we see the mid-cavitary obstruction, or we see even the LVOT obstruction, and we can easily assess the reduction of the LVOT gradient as well as the mid-cavity gradient, which really helps us in deciding which patient has to undergo a device or which patient does not need a device.
So let me tell you, the systolic anterior motion of mitral valve, the LVOT gradient can all be measured on the MR. See, MR is all the more important for the cardiac diseases because it has got a very high temporal resolution.
Do you see the mid-systolic closure of the aortic valve?
Yes, that also we can see. We can measure the gradient across. If you have a mid-cavity obstruction, MR is taking. See, it's not the gold standard as yet, I would say, the measurement of gradients and all. But yes, we can give you an idea about how much
the only
obstruction.
Potential of echo is it can be done within 2 minutes.
Sir, MRI can never replace echo. Echo is something which is so easily available, so easily. See, for MR, when I talk about MR, we are trained people. It is not easy to do cardiac MR. Needs personnel who are specifically trained for cardiac MR. Cannot be done each and every person.
So I think it's very important.
Echo
I can do an MRI right at the emergency, right in the OPD, and I just take 2 minutes to find out how much is the gradient, and I can see the concentric LV or asymmetrical hypertrophy of the LV. I feel very, very satisfied in my approach. But I'm sure sometimes when I have difficulty, I refer my patient to Priya to help me, or to Mona Bhatia to help me, so that I can delineate the information required in the reference to the therapeutic intervention and prognostic in reference to the device they use. Because we find so much of significant gradient from one posture to another. If a guy is lying down, his gradient is very different. Guy sits, his gradient is different. When he walks and speaks, there is a tachycardia, there is increased sympathetic activity, and we find a very significant gradient. Even we see post-ventricular ectopic. Just one ectopic can usually increase the gradient, and patient may collapse. So I think sudden cardiac death can be prevented to a very large extent if we use the multimodality. I think there should not be conflict. No fight between the echo.
No. So these are complementary.
It's a complementary multimodality approach is the answer. Thank you very much, Priya, for your insight to the hypertrophic cardiomyopathy. I have with me Professor G. Mahapatra, and I know him for last so many years now. He's coming regularly for this conference. Dr. Mahapatra, why you chose to come in a conference like this with a lot of spirituality and science? You are not a spirituality guy. You are purely dealing with the nuclear imaging. Do you think there is some mingling of spirituality with the nuclear imaging?
Okay. Thank you very much for inviting me to this conference, Dr. Chopra. I just want to tell you that nuclear imaging as such, also yogic exercise, meditation and other things, can monitor how much is the effect after the yogic exercise, after the meditation, after the lifestyle changes. So that is important. So we can do a baseline myocardial perfusion scan by just injecting a technetium level It's a very cheap 3,500 rupees. And then we can have a baseline study. Then after the yogic meditation and other spiritual things what you want to have, then after certain time, then you can repeat and see the improvement. That's the thing.
Dr. Mahapatra, what I'm asking you is, when we talk of spirituality, it derives the word from the spirit. When we talk of spirit, it's a consciousness based. And every consciousness controls the protons and the neutrons and the electrons. So you see the movement of atoms by nuclear cardiology or nuclear medicine, or at molecular level? What level do you work?
No. We don't
see only the effect.
We don't see proton, neutron, electron. We inject a radio tracer. The radio tracer emits gamma ray, and gamma ray is picked up by our scanner, like gamma camera or PET scanner, and then it formulates the image. So we don't see any electron.
In other words, what I'm trying to ask you is, what you see is just a cellular insult.
Yes.
But what is causing the cellular insult is not known, because the cellular insult is ultimately caused at the level of the quantum soup, or at the level of quarks or boson, or at the level of what we call as disorderliness of protons, neutrons and electrons. When there is a disorderliness, then only cellular damage takes place. So it's quite late at that time when we are doing it. And I think we may have some information, but if we have something before that, that may really help, like molecular biology, or we talk of atomic biology, when we understand. PET scan for example.
Listen, we always, when the patient in day-to-day clinical practice, we see at the cellular level, cellular integrity, a lot of new molecules have come, and already it has come and giving more and more information at the cellular level. Which
I talked to Jagat Naruda, who is an amazing guy from US. In fact, he presented a data in our CSI conference on so-called energy imaging.
Yeah.
Energy imaging. I personally feel energy imaging is at that level, much beyond the atoms and much beyond the molecules. We talk of energy. Energy, I'm sure we all know it. It's a basically at the level of the protonic energy or electronic energy, and if we are able to control at that level, it's very, very good. What do you think is the role of PET scan in today's armamentarium so far as the cardiac physiology or cardiac physiology is concerned? PET scan.
Yeah, definitely. The PET scan tells about the metabolism of the cells or tissue at a particular level. When there is a ischemic insult or the previous myocardial infarction, we can detect at the cellular level the metabolism. The metabolism is done by the PET scan.
Does the metabolism really change with the medication or with the interventions?
Yes, definitely. So if there is a metabolism persists, for example, we do as I showed you today in my presentation, we do two-phase study, the same day protocol. First we do a resting perfusion scan, find out the area of the muscles not getting blood supply, and then in the afternoon we do a PET imaging using F18 FDG, and then it shows a metabolism or metabolism still persists. It's called mismatch. Perfusion absent and metabolism present. That is called hibernating myocardium or ischemic myocardium. If it is a match defect, perfusion absent and metabolism absent, is called a match defect, it's called scar tissue.
Dr. Mahapatra, I just want to ask you a very important straightforward question. We see a lot of pulmonary embolism. And just now you heard a speaker, he said it's a ventilation perfusion scan by CT is also very, very good as compared to a nuclear scan. What is your view on this?
We have been doing regularly at Seven Hills Hospital, where I am heading the department. We do clear-cut perfusion and ventilations. So for indications are where CT angio or fail to diagnose, if it is a segmental lesion, lower segmental lesion, so where the CT cannot diagnose. So we do the first perfusion, see a perfusion defect, and if there is ventilation in that area, that is again called perfusion ventilation mismatch. So we can detect that, and then the thrombolytic. So I was asking that how soon you can repeat after detecting a lesion, give thrombolytic therapy, and after how many, what is the minimum time required? So as long as we have done so many cases, as early as 3 weeks after the thrombolytic therapy, then you can detect and see that beautiful comeback of the perfusion pattern.
Unbiased what is your recommendation when a patient has got a pulmonary embolism? What would be your first preference, CT or a nuclear scan?
In my opinion, if the facility is available, perfusion, nuclear perfusion scan is available, then I would definitely go for perfusion scan. Just give an injection and take out, see that whether the perfusion is normal. If the perfusion is normal, then I don't think there is any embolism. And again, there are two types of perfusion imaging which you do. It's called planar perfusion, another we could do the SPECT perfusion imaging. So we rotate the detector and see the slices in coronal, sagittal and peripheral slices, which improves the detection of the perfusion abnormality in pulmonary embolism.
Thank you very much, Dr. Mahapatra. I think you have brought a very important point that we can see the pulmonary embolism and perfusion deficit not only by one technology, but we can see by two technology, and we can easily say with a great deal of confidence is there is a pulmonary perfusion deficit or there is no deficit. I think both the speakers have done a wonderful job, and I'm sure this will create a huge impact in understanding the cellular death or cellular ischemia with the population rising of metabolic syndrome and obesity and hypertension in our country. Multimodality imaging is of a tremendous application today. I personally feel we should have a conference right from morning till evening only on multimodality imaging if we really want to help our patients. I think I'm very grateful to Dr. Mahapatra and Priya for being with us, and I'm sure we will meet again on many other occasions and talk on this particular approach of diagnosis and prognosis and therapeutic intervention under imaging. Thank you very much.